My partner looked at the cost of medication errors. And so at this point, let me introduce a pharmacoeconomist and my research partner, Dr. Dong Suh.
So I discuss subset of the entire study, specifically focus on our objective number 3. That is, we want to also see what is the kind of incidence of medication errors during hospitalization, and then also exam types and the causes of medication errors, and then also to estimate the excess cost of excess hospital cost attributable to medication errors. So out of 14 hospitals, we collected medication error report from 2 hospitals, and then those the patients were divided into 2 groups. One is the case patient, those patients who had at least one medication error report while they are in the medical or surgical unit of the study hospitals, and the controls are those patients who did not have medication errors. And then, so we could collect information on hospital-specific voluntary report on medication error, and also hospitals UB92 claims data in order to calculate the cost. But although I say cost here, but actually still we did not, we are waiting for get the cost to charge ratio from study hospitals. So at this moment what I can say is our study perspective should be a payer's point of view. In other words, just the hospital charge. In order to calculate cost attributable to medication errors, so we used, there are lots of methods to estimate attributable cost, but we used 2 methods. One is recycled prediction method. That is, we just want to estimate incremental effects of medication errors, holding the coefficients of all other covariates in the model. And then the other one is we used kind of a matching method. First, we match the case patients with the control patients using propensity scores within block of a hospital, or age, and the gender. And then we use the Oaka decomposition method in order to see what portion of a cost could be attributable to some variables, some observed variables, and what portion could be attributable to unobserved variables such as medication errors and also some other variables. So all costs were converted to 2008 US dollars using an inpatient hospital services price index. This table just shows characteristics of our study patients. As you can see, we have about, they collected, oops. I think this is too weak, yeah, sorry. I cannot use, the pointer, sorry. We collected data from about 57,000 patients, and out of 57,000 patients, 470 patients had medication errors. And the others are the differences between patients who had a medication error versus not, in terms of many different patient characteristics. This graph shows the incidence of medication error per 1,000 patient days. As you can see in the total column, overall 1.8 incidence rate was observed per 1,000 patient days. And this one would be a little bit lower than the previous studies because we collected the data from only medical and the surgical unit of the hospitals. And This table shows distribution of clinically important medication errors by stages of medication process and also proximal cause. As you can see here, most medication errors occur in the stages of administration and then followed by transcribing and dispensing and ordering. And transcription errors in the stage of transcribing or sleep and the memory lapse in the stage of administration, and also faulty interaction with the other services in the stage of ordering or administration, or most common medication errors. And this table presents types of medication errors by different stages of a medication process. And as you can see here, wrong time in the stage of dispensing or administration, and the wrong medication in the administration or dispensing stages, or wrong dose in the stage of administration and transcribing stages are common medication errors. And this table presents medications involved in medication errors. As you can see here, about half of the medication errors involve the therapeutic class of antibiotics, opiates, insulin, or electrolyte and fluid, or anticoagulants. This table shows attributable cost to medication errors. As I mentioned, we used the two methods. The first one is the partial OACA decomposition method with a GLM, and so, or sometimes this is called also recycled prediction method. As you can see here, about $6,000 can be attributable to medication errors. So this one is where we estimated a coefficient based on entire our sample, and then we used that coefficient for medication error, the patients who had medication errors. So this 6,000 can be interpreted as if patients who experience medication error were not to have such medication error, their hospitalization cost could be reduced by about $6,000. And the bottom portion is based on two stages of estimation. First, we matched patients using a propensity score, and then we used the OACA decomposition method in order to see what portion of our medication, the cost could be attributable to covariate, the variables which we used, and then also what portion of a cost can be attributable to medication errors. So as you can see here, the differences in cost between medication error versus non-medication error is about $40,000. And of those $40,000, about $34,000 can be attributable to the differences in patient age, gender, and the comorbidities, and some other variables, and also hospital length of stay, etc. And then also, but about $6,000 can be attributable to medication errors and also some unobserved variables. Our study actually found economic burden of medication errors enormous. So,
okay, so what's the impact? Well, this study was among the first to qualitatively describe what it is that nurses do to intercept medication errors and keep their patients safe, and then quantitatively link those processes to fewer medication errors across a variety of multi-site units. So what we found is that medication errors, not surprisingly, are costly, that there are specific things that RNs do to keep their patients safe, but there is variability across RNs and across units in the frequency with which they engage in these more safer or higher order level processes. And those processes are indeed affected by the culture in which they work, the nursing practice environment, and adequate staffing.